Hello and a wonderful good afternoon from winter, snow and cold Bavaria.
Yes, here in Bad Birnbach, it's not white here inside. It's white, but it's
But it's
cold,
cold.
cold. Welcome to our first academy this year, online academy, the FotoFinder and Friends edition, with a very special topic.
People, we wish you a wonderful start in this beautiful year 2025. We hope that you all be always healthy and successful, joyful in what you do, and hope to see you also in live events in the upcoming month. But as Catherine said, today we have a very interesting topic to start the year, this academy year.
Exactly, with the dermoscopy of skin of color. Very important topic, becoming more and more important worldwide, right?
Absolutely. And I think there is a lot to learn. We are every time really excited and surprised, Catherine, by the pictures we see, especially last time. I think it was in an event I saw some UV dermoscopy images with DL5 of the skin of color, and it just looks like completely strange. I've never seen something like that. You would not guess it's skin, actually.
Yeah, and we have to learn to interpret, and yeah.
And that is why we are here to share with you the knowledge of two of our close friends and experts in this field.
Exactly, because there are not so many super experts in this field, but we have two of them here with us. And the first of them is in...
Today, he is in a special place.
They are both not at home, actually.
That's true. Where do we start? Do we go to Vienna or to Riyadh?
Let's go to Vienna because it's closer. It's 2 hours from here.
Yeah.
And we have Ahmed Sadek sitting in his hotel in Vienna giving other lectures. Hello.
Hi, how are you doing?
Hello. So everybody knows Ahmed Sadek. He's very big specialist and dermoscopist and ambassador of dermoscopy, normally in Egypt. He's also for sure in the board of the IDS, and he's giving lots of talks. And now he's talking in Vienna, right?
Yes, definitely. I just finished my second lecture for the day, and I jumped back to be able to join you. And I believe the weather is not so much different than in Bad Bernbach, but the thing that you're much used to it, not myself. But I'm really glad.
Thanks for being with us despite your busy program today. And again, as Catherine said, you have been really teaching us a lot about the skin of color. Especially in Cairo, you really deal with all phototypes of skin. And I think that makes your job so incredibly interesting and also good for us, because you challenge the FotoFinder as nobody else, I can tell you.
And we learn a lot from you also in terms of dermoscopy used in aesthetics.
Absolutely.
It's a lot to learn. And I hope you have a good Viennese coffee, maybe, and some sweets, Sachertorte or...
And schnitzel.
Schnitzel.
Okay, that's definitely special. People, let us take you from the capital of Austria, Vienna, to the capital of Saudi Arabia in Riyadh. You're surprised. Our dear friend Enzo Enrichetti is today with us from Riyadh. Enzo, you are coming from a marathon of lectures, I suppose.
Yeah, hello everyone. It's a real pleasure to meet you. Yes, I've done 8 lectures, but this is the most important one, the most enjoyable one, I'm sure, at least for me, because skin of color is a very important topic, and it's very enjoyable because we don't know too much, we are discovering it, so I really like it. So I would be very pleased to share with you some of my experience.
Enzo, let me tell our audience, you have been with us a couple of times in the academy, and I have seen your lectures in Italian language, in English language, and again, it's every time impressive looking at your cases, your approach, and you're right. When it comes to dermoscopy, Catherine, the last 30 years of history of this company, we've been dealing a lot with pigmented lesions of fair type of skin.
Yes.
And in the world of skin of color, there is a lot of inflammation. There is a lot about inflammoscopy at the same time. And I think that is also a challenge when it comes to calibration of cameras, you know, to colors. So it's really, really not only from the point of view of a physician and patient, but also from a technical point of view. It's a very, very interesting area. And that's why we look forward to your presentations today, gentlemen. Good. We start with Enzo?
Enzo.
Okay. Okay, great, guys. So let me share my screen. As Moa said, I will talk mainly about inflammatory conditions because it's the main topic when it comes to skin of color. Let me share my screen. Just a moment. Okay. Okay, can you see it? Okay, let me put it full screen.
Yeah, it's visible. Just go to full screen and we can start. Yeah, perfect.
Okay,
Perfect.
can you see it full screen?
Yes, perfect.
Okay, great, perfect. So these are my conflicts of interest. And I would like to start with this image, okay? This is, of course, not dermoscopy. This is not dermatology, okay? We have something strange in the chest of these two patients, as you can see here. This is the main vessel of our body. This is aorta, okay? And as you can see, even if we are not, you know, radiologists, we can see something unusual. We see a dilation of this big vessel. And this is, of course, aortic aneurysm. But of course, apparently, this does not mean anything, but I would like to show you which are the owners of these two radiological pictures. These ones, okay? These are patients belonging to different skin type, different skin race, okay? And basically, there is no difference when it comes to this disease, but also several other diseases which are not, of course, dermatological conditions. So other specialists have, let's say, an easier life when it comes to diagnosis, even though sometimes we can find, of course, some differences, especially in terms of therapeutic response, but from a diagnostic point of view, their lives are much more easy. Okay, let's move to dermatology. Apparently, these two cases may have something in common, okay? I don't know if you have an idea, I don't know more if we can use the chat, I don't know. But anyway, if not, I will comment on these two cases. Here on the left, we have a big patch, okay? And we have several other lesions all around the back of this patient, okay?
Enzo, let me maybe clarify for our audience. It's for us very important that you participate in chat and ask your questions. I mean, in many cases, while Enzo is talking, also Dr. Sadek can comment on it, or vice versa. But it's for us important that the audience participates in chat, and chat is open, okay? Enzo, so anytime you have any question, you can also ask if they want to go for yes, no. We would like to keep it very interactive.
Okay. So guys, if you want to break in, please do it. Otherwise, I will go on by commenting the pictures by myself, but it would be great if you can interact with me because, you know, it's something new. So it needs to be discussed even with you, and I'm here for this. Anyway, on the left, what do we have? We have, okay, pityriasis rosa, but which one? Vanessa said pityriasis rosa. The one on the left, on the right? The one I was commenting. Left, perfect. Okay, I agree with you because I was commenting in that direction because we have, let's say, a bigger patch, and we have these smaller lesions all over the back of the patient. So the first impression, I agree with you, it would be pityriasis rosea. Okay, this is also my first clinical impression. On the right, this is to me a little bit more difficult because we have this papules all around the back of this patient, okay? So I don't know if some of you, you know, has an idea. Okay, so left pityriasis rosea, on the right dermatitis. Okay, I don't know microbiana, honestly. Okay, Nkechi, our friend. said pityriasis rosea, also on the right, lichen spinulosus, someone else. Okay, great, great. These are the main differential diagnoses. Okay, let's see the diagnosis. Okay, on the left, we have atopic dermatitis, actually. We have a discoid eczema with, you know, this heat reaction with satellite lesions. On the right, Nkechi was right, we have pityriasis rosea, a popular variant, because when it comes to skin of color, we can have an uncommon picture, and this popular variant is pretty much frequent. Okay, and what about this? The question now is, are these two patients, do these two patients have the same condition? Okay, do we have here the same condition? Yes or not, in your opinion? I would say not, honestly. What about you? So let's go. You agree with me. If you don't answer, it means that you agree with me. Okay. Not. Okay, not. Perfect. But actually, both of them had lichen sclerosus. So you can see how the clinical picture of the same diagnosis may differ according to the phototype. Okay, in skin of color, lichen sclerosus may be very dark because, you know, of pigment release, and we can see, of course, a picture like this. On the left, we have the classical presentation in a Caucasian patient. Okay, these differences are seen on clinical ground, but they are seen also on dermoscopy. For example, in these two cases, in these two images, we have the same diagnosis, which is eczema. We are used to see the picture on the left because, you know, we have more data published in Caucasians, and in eczema, we have the cluster dotted vessels and the yellow scales and crusts. The picture in skin of color is completely different. We have no vessels, basically, and we have these brown crusts and scales because in skin of color, we have melanin exfoliation. So dermoscopic patterns may vary according to the phototypes, and these differences may be really remarkable. Of course, this is valid also for tumors. For example, in these two images, we have two cases of neurofibroma. And you can see that on the right, we have less inflammation and we have more bright white areas because in skin of color, we have a higher tendency to fibrotic reaction. Okay, so why there is this difference between dark skin and fair skin on dermoscopy? Basically because of these 4 points. Of course, we have a darker background, and this may, you know, cover some dermoscopic findings, for example, vessels. On the other hand, we have also different reactions, different pattern of reactions of the skin. For example, in skin of color, we have a higher tendency to pigment lability. This means that we will have more pigmented structures. In skin of color, as I said, we have more sclerotic reactions, so we will see much more bright white areas. And finally, we have much more follicular reactions, so many conditions will display follicular findings. And then, besides all of this, we have some conditions which are peculiar, or let's say mainly seen in dark skin. For example, I've never seen, honestly, a recurrent infundibular folliculitis in an Italian patient, in a Caucasian patient. Okay, so we also have to consider this. Okay, so let's move to the heart of my presentation. Let's start with papillosquamous dermatosis. If I show you this case, of course, we can have an idea, I think. I don't know if any of you has an idea, but come on, it's not impossible from a clinical point of view to make the diagnosis, especially for our colleagues dealing with dark phototypes. Nkechi, you are very active. Tell me, what could it be? We have, you know, ill-defined brown patches, scaly. So when we have, yes, parapsoriasis, it could be parapsoriasis, of course. Let's think about more common conditions. Okay, so one of these differential diagnoses could be eczema, okay? Because we don't have to expect redness, of course, in skin of color, especially in very dark phototypes. Okay, some of you said fungal dermatosis. Okay, it could be considered into the differential diagnosis, but in, let's say, dermatophytosis, we have much more well-demarcated margins, and also the shape of the brown areas is different between the different areas of the lesion. Okay, so some of you, Enrichetti and Nikruka, said eczema, atopic dermatitis. Okay, it could be. But let's take a look at dermoscopy now. And what do we have? We have brown crusts and scales. Okay, so as I told you before, this is the main dermoscopic picture of eczema. Of course, this is completely different to what we can see in Caucasians, in fair skin patients, because we have these cluster dotted vessels and yellow crusts and scales. So the marker of eczema is this one. We have brown scales and crusts. This finding is not visible in other conditions. In psoriasis, for example, we cannot see this. Sometimes we can see this finding in tinea corporis, but usually these scales and crusts are located at the periphery of the lesion, and most importantly, in tinea corporis, we have follicular findings because, you know, the fungus has a tropism for the follicle, so we will see broken hairs and perifollicular scales. Okay, eczema, perfect. You can see another case. This is pretty much typical from a clinical point of view. This is atopic dermatitis, come on, no doubt. And we can see that we don't have yellow scales and crusts, but just brown scales and crusts. Okay, another case. So, do you agree that this is eczema? I think so. We've discussed a lot about dermoscopy of eczema. We still have white scales, okay, but this is not specific. And we see brown crusts and scales. We don't see vessels, okay? So again, this is eczema. On the other hand, I would like to show you a typical case of psoriasis. From a clinical point of view, we don't see a very, let's say, a relevant erythema. We see mainly brown backgrounds, brown halo, and sometimes in, let's say, phototype 4, sometimes in phototype 5, we can see that the plaques are, let's say, purple, brown purple. And then we have the scaling, which is the same as the fair-skinned patients. We have chalky white scales and not silver white scales. I don't like to call them silver white scales because it's not silver, it's white. So chalky white, in my opinion, would be much better to describe the scaling of psoriasis. And what about dermoscopy? As I told you before, in eczema we don't see vessels, but in psoriasis we see a lot of vessels, and they are similar to what we can appreciate in fair-skinned patients. So we have diffuse, uniform dotted vessels. And of course, we also have white scales, but white scales, especially in skin of color, are not specific because, as I showed you before, we can also appreciate white scales in eczema. So we have to rely for the diagnosis on the presence of dotted vessels and, let's say, the lack of brown scales and crusts. Of course, we can see 1, 2, 3 brown crusts, but they're not prevalent. We have to, in general, in dermoscopy, we have, especially in inflammoscopy, we have to evaluate the prevalent finding. Okay, what about, I told you that in skin of color, we may have several variants of atopic dermatitis. This is one pretty much common, the follicular variant. And what do we have on dermoscopy? This variant may be mistaken, for example, for lichen nitidus sometimes. We have basically follicular plaques, as you can see here, and we have white halo. Okay, follicular plaques are due to the presence of follicular hyperkeratosis, and the white halo is due to perifollicular acanthosis. And as you can see, okay, they are follicular, so the lesions, okay, the plaques have the same distance among each other. They are equidistant. And this is important to, to understand that these lesions are follicular. Okay, what about this papular atopic dermatitis? This is another common pattern of atopic dermatitis. What do we have in dermoscopy? We have this. We have a central brown or yellow crust and these peripheral white lines, the so-called starburst pattern. More or less, this pattern is the same as prurigo nodularis, okay? Because you know that papular atopic dermatitis is due to the scratching. So it's not, let's say, in most cases, a primary lesion, but it's a secondary lesion. Okay, what about this? It could be anything. It could be, for example, warts. It could be molluscum. I don't know. Do you have any other idea? It could be, of course, we just discussed about it, follicular atopic dermatitis, but are we sure? Come on, it could be, okay, atopic dermatitis, but with warts, with molluscum contagiosum. We know that the atopic patient is really prone, really keen to develop viral infections. Okay, let's see dermoscopy. What do we have? Let's see. Okay, atopic dermatitis sketchy. Okay, yes, but it's not, okay, allergic contact dermatitis. Okay, so eczema. Okay, that's right. But, you know, the presence of this let's say, small papules that are asymmetric may raise, you know, the suspect of something viral. But if we use dermoscopy, also like a nitidus, yeah, I told you that follicular and papular atopic dermatitis may be mistaken for like a nitidus, but the pattern that you can see is this one. We have a central brown crust and peripheral white stria. So this is, as I showed you before, the typical pattern of papular atopic dermatitis. Okay, so let's remember this pattern because it's very characteristic. It's very similar to prurigo nodularis. When we have this pattern, we can be pretty much sure that it's not molluscum contagiosum, it's not a wart. Molluscum contagiosum in skin of color, let's say that displays the same pattern more or less as fair skin. Okay, prurigo nodularis, as I told you before, we have pretty much the same pattern of papular eczema, and we have the same pattern as seen in fair-skinned patients. Okay, so we have this peripheral white stria with a central crust, erosion, okay, or white fibrotic area, and the presence of this peripheral radiating projections are very characteristic for prurigo nodularis. Okay, so what about this? In this case, this is a very dark skin type, of course, skin type 6. What do you think about this? What could it be? Now you have to help me. Okay, so what could it be? Okay, lichen planus and lichen planus. Okay. Okay, and what about, okay, could it be, I don't know, prurigo nodularis? Huh? No, no. You are right. You are right, because this is, of course, lichen planus. From a clinical point of view, we have these flat, well-demarcated papules, which are silver in color. Of course, they are not purple. Okay, the color is completely different, skin of color, and we have the Wickham stria. So we don't have, regularly distributed white radiating lines at the periphery of the lesion, but we have these crossing white lines. Actually, in skin of color, they are not white; they are light blue. So we have this crossing light blue lines, which are, of course, Wickham stria, and we can do the diagnosis. You can see the difference in skin of color. We have a light blue color, and we don't see vessels. In Caucasians, we see vessels at the periphery of the Wickham stria. This is the difference between prurigo nodularis and lichen planus. In prurigo nodularis, you can see these regularly distributed white radiating projections at the periphery, and in lichen planus, we have light blue crossing lines. What about this? This is lichen planus also. Especially in skin of color, we can see different morphologies of the Wickham stria. They are not always reticular. This is a pretty much common shape of Wickham stria, annular Wickham stria, and we have to learn also this pattern when it comes to lichen planus. You can see that the color is not white, is still light blue. Okay. Now we have these two patients. This is a pretty much common clinical scenario in skin of color. We have hypopigmented papulosquamous or papular dermatosis. The main differential diagnosis is between lichen nitidus and frictional lichen dermatitis, which is due to the scratching. Let's say it's common in atopic patients. I don't know, which one do you think is lichen nitidus, left or right? Help me, guys. Left or right? Simple. Left. Okay. Left. I agree. It could be. But are we sure? No, we cannot be sure. Okay, so let's go on. Now we are, let's say, more sure. On the right, we have dotted vessels on a white background, and there is also a little bit of peripheral white striae. But, the main clue here is the presence of dotted vessels, because when we scratch the skin will respond by thick itself, but also by an elongation of dermal papillae. So we will see dotted vessels, okay? And the background is white, so we can see the contrast and we can appreciate the vessels. On the other hand, in lichen nitidus, we see just well-demarcated white globules, okay? Devoid of skin markings. This is important because in lichen nitidus, we have a flattening of the epidermal-dermal junction, so we will not see, sorry, skin markings, skin lines. Okay, so what about this? Lichen nitidus, frictional lichen dermatitis, follicular eczema, please respond. I would say, I don't know, popular atopic dermatitis maybe, but also frictional lichen dermatitis, but also lichen nitidus, come on. Follicular eczema, okay, frictional lichen dermatitis, okay. Flat warts, I didn't consider flat warts. Flat warts may be honestly similar to frictional lichen dermatitis, but the lesions are more confluent and the vessels are not very well visible. Okay, they are more subtle. Anyway, let's take a look at dermoscopy. What do we have? We have a friend. You can see here, there is a friend of us. Huh? Can you see it? Okay, this is, what's this? Yeah, of course it's frictional lichen dermatitis because the patient scratched the skin, but we have the brown triangle. So this is an Hispanic patient, is not so dark in terms of phototype. So we can see the mite, okay, and we can also see the barrow. So this is scabies. So we have to pay attention in skin of color because we can see scabies with a hypopigmented papular presentation, but underneath we can see some surprises, and including our friend the mite. Okay, so this is scabies. Of course, we can make the diagnosis of scabies very quickly because we are really used to see this pattern. We have the brown triangle, which represents the anterior part of the mite, and we have the barrow. Okay, this is very easy. Okay, but what about skin of color? It's not so easy in my opinion, because in skin of color we have a dark background, we have a melanin exfoliation, so the mite may be covered by melanin exfoliation, or it may covered by the dark background, and the melanin exfoliation may be mistaken for the mite. So the main clue in scabies of dark-skinned patients is the presence of the barrow. So this serpiginous white tract. This is the main clue. This is a photo, Errichetti photo. Thanks for this that we published in our books. Here, of course, we can see the barrow, this serpiginous gray tract, but honestly, I don't see the mite. So again, This is just to show you that in scabies, that is, you know, a very easy diagnosis to make on dermoscopy. We have to pay attention when we deal with dark-skinned patients, because the main clue is the presence of the barrow. Okay, and what about this? This is a very dark phototype 6. Could it be a barrow? Maybe, but I'm not sure, honestly. There are some situations in which even the barrow may be not so easy to be appreciated, okay, because we have a lot of scaling in skin of color, we have this very dark background, we have a lot of melanin exfoliation. But if we use, you know, the UV dermoscopy, okay, with UV dermoscopy, we discovered a lot of things and we published many papers. We can see that this serpiginous, let's say, light blue tract may be recognizable as a barrow. In this second case, of course, we see the mite, we see the barrows, but if you use UV dermoscopy, we can also appreciate something else. Can you see these roundish oval structures, green structures? These are the eggs of the mite. This is impressive because if we use our dermatoscope, UV dermatoscope, and we zoom in a little bit the skin, just by using our mobile, we can appreciate really interesting structures. Okay, okay, very quickly. If I have time more, I would go very quickly through facial inflammatory dermatosis. As you can see, they may look really differently, okay, really different between you know, fair and dark skin, but we know that in Caucasians, in fair skin, we have some findings helping us in making the diagnosis of these conditions. If we have polygonal vessels, we have to speak about rosacea. If we have yellow scales and crusts and patchy dotted vessels, this is typical of seborrheic dermatitis. And then we have to remember other two things. Orange. If we have orange and focused vessels, we have to think about granulomatous dermatosis. If we don't have vessels, or we have just blurred vessels, we have to think about granuloma faciale. When we have follicular plaques, if they are protruding, we have to think about demodicosis. If they are not protruding, we have to think about DLE. Very quickly, here we have a case. It could be seborrheic dermatitis. It could be rosacea. Let's take a look at dermoscopy. We have vascular polygons. So this is, of course, rosacea. Okay, what about this? This is more challenging. We have orange. Do we have focused vessels? No. So it's not a grammatose condition. This is granuloma faciale. That we all know that this is not a grammatose condition. It's a chronic vasculitis mainly involving the face. What about this? This was really severe as you know, facial dermatosis, and it could be anything. Come on, could be psoriasis, could be, I don't know, mainly psoriasis. Do you have other ideas about this? Seborrheic dermatitis also. I don't know, maybe sarcoidosis, because it may mimic everything. Okay, but let's take a look at dermoscopy. What do we have? We have a lot of pustules, we have crusting, and we have this protruding follicular plaque. So actually, this was a case of demodicosis. Unbelievable, but it was. We treated the patient with doxycycline. So again, these are the things we have to remember for fair skin. And now we will discover if these findings work for dark skin. Let's remember polygonal vessels, yellow scales and patchy dotted vessels, orange and follicular plaques, and these two questions. I made it very simple. Okay, let's start. We have this case. It could be anything from a clinical point of view. I don't know if you have any suggestion. Okay, some of you said what? Okay, leprosy. Some of you said lupus. Okay, but it could be also, come on, a strange seborrheic dermatitis. Okay, let's take a look at dermoscopy. What do we have? We have a lot of follicular plaques. So now the question is, are they protruding or not? They are not protruding, so this is discoid lupus. Very well. So for discoid lupus, our old criteria work. What about this? It could be rosacea, it could be demodicosis. Do you agree? Rosacea, demodicosis. My first impression was demodicosis, actually. Sorry, was rosacea, actually. But let's take a look at dermoscopy. What do we have? We have a lot of protruding follicular plaques. So the diagnosis is demodicosis. And the dermoscopic picture is the same as seen in fair skin. What about this? Okay, let's take a look at dermoscopy. Could be DLE, could be sarcoidosis. Let's take a look at dermoscopy. What do we have? We have just polygonal vessels. So this is rosacea. Nothing different. Okay, so even the polygonal vessels may work. Let's say till phototype 5, they may work. It's more uncommon to see the polygonal vessels in phototype 6, but honestly, rosacea in phototype 6 is very, 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 very rare. Okay, and what about this? Oh, sorry. What about this? What could it be? Because this is not so simple. DLE. Okay, I agree with you. DLE. DLE because we have these round lesions, scaly lesions. Let's take a look at dermoscopy. Do we have follicular plaques? No, no. I see just, white scales, okay? And we see hypopigmented areas, which are, of course, seen also in this case on clinical ground. We have some dotted vessels here, as you can see, okay, here, classed dotted vessels. So we, according to the flowchart I showed you before for fair skin, okay, Enrichetti is right, is seborrheic dermatitis because we have dotted vessels. So for seborrheic dermatitis of skin of color, the presence of dotted vessels may work, okay, and they are visible because the background is changed, okay, it's white. But usually it could sound strange, but we don't see very, very often yellow scales. Okay, so seborrheic dermatitis is great. And what about this case? Okay, this was a patient that I saw a few weeks ago. Clinical differential diagnosis, DLE. Okay, DLE, I agree, DLE. But let's take a look at dermoscopy. Yes, of course, we have something looking like follicular plaques here, but honestly, these are not follicular plaques because this is the skin of the patient. When we assess dermoscopic image, we have always to examine the perilesional skin to understand what is pathologic in the lesion, okay? So here, the main dermoscopic finding is the yellow color, okay? Some of you said granuloma annulare. On the face, it's not so common. This was anyway a grammatous condition, okay? It was sarcoidosis, okay? When it comes to grammatous conditions in skin of color, we don't see orange, we see yellow because we have a brown background. So it's, due to the background. And what about this? This is the last case. We have this lesion of the nose. Could it be sarcoidosis? Yes, why not? Could it be, yes, some of you said sarcoidosis, lichen planus? I don't know. It's, I don't know. Rhinophyma, okay, leishmaniasis, granuloma faciale. Some of you said granuloma faciale. Okay, so let's consider sarcoidosis, rosacea, and granuloma faciale. Let's take a look at dermoscopy. Let's take a look. What do we have? These are not follicular plaques. This is the skin of the patient. We have a little bit of scales. Honestly, I don't see the 4 findings that we have to remember. I don't see orange. I don't see plaques. I don't see vascular polygons. I don't see dotted vessels. So this is a diagnosis of exclusion in skin of color. This is granuloma faciale. In granuloma faciale, yes, we can have something. We have brown orange areas, not orange, and we don't see anything else usually. So this is granuloma faciale, okay? So we have to change a little bit our flow chart used for fair skin, and in particular, rosacea, okay, it's fine. DLE and demodicosis, it's fine, it works. But in grammatous dermatosis, we see yellow various, yellow orange areas, And in granuloma faciale, we see brown, orange areas. In seborrheic dermatitis, we see patchy dotted vessels mainly and hypopigmented areas. That's it. So we have to consider this flowchart when we deal with facial dermatosis in skin of color. I wanted to address, facial dermatosis because we can spare a lot of biopsies and we can avoid, scarring. So to me, it's very important. Okay, sarcoidosis, you can see yellow, okay? And you can appreciate the difference between dark and fair skin. Usually in dark skin, we don't see that, let's say in very dark phototypes 5 and 6, we don't see the vessels, okay? So we have to rely on the color of the background. Okay, so final remarks. For the main differences between fair and dark skin, vessels are less commonly seen in dark skin due to the pigmented background, of course. In eczema, we don't see, we can see, of course, yellow scales and crusts, but they are mainly replaced by brown scales and crusts. And some findings may be masked or neglected due to the dark background, for example, as I showed you in scabies, and color of some dermoscopic clues may be different, as I showed you before in granuloma faciale and in sarcoidosis and in lichen planus. Another last case, here we have this patient with all of these papules, itchy papules. This is dermoscopy. This is pathognomonic. We have this star-like brown areas with a white halo. This is Darier's disease. And this is, of course, the same as we can see in Caucasians. The only difference is the color of the central star-like area. In Caucasian is yellow, in dark skin is brown. So we can see how the background may change our findings, as, guys, happens in other, let's say, scenarios of our life. Thank you very much. That's it. I hope you enjoyed it.
Very good, Enzo. I really liked your approach to make this direct comparison. It's quite, the contrast is huge.
Yeah, absolutely. But it's easier to understand, in my opinion, dark skin if we start from what we know, especially for colleagues dealing with both fair and dark skin. But it's wonderful, really. And as I told you before, I enjoy skin of color much more because even from a clinical point of view, the diagnosis is very difficult, even for colleagues familiar with skin of color.
No, I definitely agree with you. That is, I was last year in the National Congress in South Africa, and in a couple of sessions, that's exactly what the doctors have been reporting, because the differential diagnosis is much more difficult clinically compared to the fair skin.
Absolutely.
Very good, very good. Dr. Sadek, well, how do you see that?
Hi, Enzo. That was really great and impressive indeed. And I'll try to complete the story of the dark skin by presenting about melanocytic lesions and skin tumors as well. So I cannot share till Enzo finishes sharing. Okay, perfect. Just a second.
Dear audience, please feel free to add your questions. We will definitely, once Dr. Sadek has finished his presentation, take some time to discuss and exchange some knowledge between us. Okay, so feel free to share your questions, please.
Definitely, we'd like it to be an interactive session as much as possible, because this way we will be able to exchange knowledge and get the most benefit out of the session. So is my screen clear for you? Perfect. Let's start. Okay, so my objectives today is to talk a little bit about the optics of dermoscopy, also highlighting the structure of skin of color versus other races and the specific optics of skin of color. And that's why we are going to see the differences. The differences are much more appreciated in cases of inflammatory disorders because there is much more hemoglobin that is usually apparent in fair skin phototypes, but is masked by melanin in skin of color. It's not the same thing for melanocytic lesions, but let's see how skin of color behaves in a different way than fair skin phototypes. Okay, so this is our skin, our passion, our daily practice, and this is how it looks from inside. It's not just the surface of the skin. The color of the skin, as we all know, is appreciated by the amount of melanin present, hemoglobin present, keratin, and carotene. So color is not that simple as one might think, that it's just the amount of melanin, whether it's eumelanin or pheomelanin. It's a bit more complicated than that. Also, the thickness of the skin and the presence of all those structures deep inside. So, in order to reach a proper diagnosis, we always have to climb the pyramid of diagnosis. And dermoscopy helps us definitely by the third step, which is the visual aid devices. We start by history taking, proper examination, then comes the role of dermoscopy. That's why Enzo have been showing you clinical and dermoscopic. It's not just about putting your dermatoscope on the skin and finding the diagnosis. Okay, I always like to start by this citation, because this is what we are going to do now. We are going to use the dermatoscope to solve the puzzle. And actually, dermoscopy for me is for literally every skin lesion. Today, if you search with the keyword dermoscopy on the Medline database using the PubMed search engine, you'll find that there are more than 9,100 papers. 18 months ago, it was almost 15% less. So this is a very dynamic area of research. People are gaining much more interest, and there are much more findings thanks to the work of all the dermoscopists all over the world. So every day there is something new to learn and to teach and to think about to get to the future. But unfortunately, if we add the keyword skin of color to dermoscopy, the number is like 8% of the total. And if we go for dermoscopy and ethnic, it is less than 1%. So this is a very interesting area, because it has not been researched thoroughly till Enzo started doing all this great effort researching dermoscopy of darker skin colors. So a little bit back to the basics, to be able to understand and appreciate the differences between the fair skin and the dark skin. Dermoscopy basically is based on the light physics. Which light shall penetrate into the skin in order to be reflected by a certain structure, giving us the impression that this structure is present. That's why we use the parallel polarized light, which are presented in this image by the dashed red line, to appreciate these more superficial structures. And we use the cross-polarized light that is presented in this graph by the straight black line that goes through multiple refractions in order to be able to penetrate deeper into the skin, down to the level of the papillary dermis. And don't forget that blood vessels are either oriented perpendicular to the skin surface. So when I'm looking from up here, I just see small dots if I'm using low power magnification. Or they are running parallel to the skin surface, so I'm appreciating lines. And same rules apply. Don't press hard on the skin, or the blood vessels will blanch. And this is of utmost importance when dealing with skin of color, because of the paucity of appreciation of the inflammatory component or the blood vessels, because melanin is diminishing the appearance of hemoglobin. So different colors that we all have all around the world. And what's the difference? Regarding structure, it's the same. Regarding the number of melanocytes, it's the same. But it is the activity of the melanocytes. It is the amount of melanin that's produced. It's the amount of melanin that is carried by the melanosomes all through the thickness of the epidermis. And this was researched. And we know that darker skin has the highest amount of melanin for sure. Same number of melanocytes, as I just mentioned, but it also is thicker. It has the highest number of corneocytes, adding to the appreciation of the dark color. On the other hand, it has less ceramides with increased transepidermal water loss, rendering it more sensitive to some inflammatory conditions. It's the least type to get contact dermatitis, and it has more adnexal structures and more flora than the other races' skins. So possibilities of more inflammatory conditions. Okay, thanks to the science that was created by the laser masters, Anderson and Parrish, we have insight into how our skin really works on with light or deals with light. Whenever light is introduced to the skin, it either is absorbed, transmitted, scattered, or reflected. And the one is appreciated during dermoscopic examination is the part that it is reflected. And we know, based on the chromophores that are present over there, with the visible light that we are utilizing in dermoscopy, we have this window, which is just below 500 to a little bit below 800. And we see here that the hemoglobin and the melanin are competing on the light that's incident from the dermoscopic structures to the skin. Okay, here is the initial work of Rox Anderson and John Parrish that was published more than 40 years ago, almost 45 years now. And you can see how part of the light is reflected and remitted from the skin and less is absorbed. And the ones that are reflected and remitted are the ones that give us the appreciation of the skin structures. And they have also concluded that the remission and reflection from fair skin is more than what happens with darker skin, putting in mind that the longer the wavelengths, the more the ability to penetrate deeper into the skin. So let's have an example for that. We have this young gentleman who is suffering from this change in color of his skin. You cannot appreciate much whether this is melanin or hemoglobin. Moha, do you want to say something? I see a raised hand.
Dr. Sadek, the one thing I wanted to know is in such cases, do you use also clinical pictures with UV?
Yes, yes. Using the different lights help us to get all the data that we need. I can utilize natural light, I can utilize polarized light, and I can utilize UV light in clinical imaging and dermoscopy as well.
Okay. That's what I wanted to hear, sorry.
Yes, no problem. And kindly let me know if I missed any question of the audience as well. Okay, so back to our presentation. Back to this gentleman. As you can see, this discoloration is present on the sun-exposed parts of his face and the neck as well, including the opening of the shirt, the nape, even the upper eyelids, excluding the lower eyelids. Likewise at the auricles. But here, it's really difficult to appreciate whether it's melanin or hemoglobin. That's why we apply our dermatoscopes to have an impression of what's really going on deep in the skin. And as Enzo has just mentioned, here we can appreciate that this is hemoglobin more than melanin. This was not an easy case to be solved just by dermoscopy, because as you see over here, we have this sort of poikilodermatous reaction or poikilodermatous-like reaction, because we cannot appreciate atrophy over here, as this case was actually a very rare case of primary cutaneous amyloidosis of the poikilodermatous type. So this was just to let you know what I'm talking about. Always put in mind that same principles apply for fair skins, apply for dark skin. For example, this is a 5-year-old boy. He is suffering from this pigmented lesion since birth. And when we apply our dermatoscope, we can have those two images. Those two images are for the same lesion, taken by the same dermatoscope, same camera, same physician, but they are totally different. On the left, we can appreciate the scales that are obscuring the radial lines that we see arranged all around the lesion in the image on the right. So when we are dealing with dark skin phototypes, don't forget about wet dermoscopy, because it helps you to see deeper into the skin. Also, as I just mentioned earlier, this man, 72 years old, suffering from this pink nodule on the left malar region of 2 years duration. And again, if we apply pressure with contact dermatoscopy, as in the image on the left, we cannot see the blood vessels. But the blood vessels are much more appreciated on the right part, and this will lead us to the diagnosis of a keratoacanthoma with the central keratin hub and the radially arranged linear blood vessels at the periphery. So we can conclude that we use the same principles, the same techniques, but we have to understand that the behavior of the skin to the incident light is different. We have to be fully aware of that to be able to appreciate and comprehend why the appearance can be different at certain situations, especially the ones with more hemoglobin as a chromophore of the skin. Okay, so let's go to the pigmentary disorders, the melanocytic lesions, and let's have a look. On the left, this is a dermatoscopic image of normal skin. And if we have a thorough look, we'll find that it is as if the reticular fine network of any junctional melanocytic nevus in fair skin phototype. So, as if there is melanocytic proliferation, but there is no melanocytic proliferation. It's just increased melanin deposition, but it follows the same rules of benign melanocytic proliferation in fair skin phototype. So we get the same appearance. So darker skin looks as if it is melanocytic, benign, nevi in fair skin phototype. So this is similar behavior because these are the same skin structure, and this can change according to the part of the body to influence the appearance of the skin. Definitely for the face, where there is a pseudo network, then the abundance of the sebaceous glands will also lead to dilution of the melanin, so it will be always evident over there. So this is to think about it. It's the same thing, but in different skin types. Okay, this paper was really interesting because it looked at different pigmented lesions. And actually, in spite of that the observers were not experts at that time in darker skin phototypes, but they could reach the diagnosis in 97% of the cases because the structures were the same, the patterns were the same, and the diagnoses were also easy to get to. So let's have a look over here. This is a nevus, and this is the fine reticular pattern. Yes, there can be some more homogeneous, darker hyperpigmentation, but you cannot miss the benign nature of this melanocytic proliferation. Again, if we go for blue nevi, the homogeneous appearance, and if we go for melanomas, you cannot miss the findings that you already know about benign lesions and about malignant ones. Here again, the pseudo network pattern on the left, because the lesion is on the face, and the globular pattern on the right when we're dealing with a cellular lesion. Okay, that we have to mention the difference, because it was statistically found that acral melanocytic lesions have the highest portion of melanocytic lesions in comparison to acral lesions in fair skin phototypes, meaning that we all know that people with dark skin have less melanocytic lesions than people with fair skin. But the chance that a person with dark skin to get an acral melanocytic lesion is much higher than the chance for a person with fair skin. That's why we find much more acral melanocytic nevi in darker skins, and also acral lentiginous melanomas in darker skins. So less nevi in darker skins, less melanomas in darker skins, but the portion of melanomas in darker skins is mainly an acral lentiginous melanoma. On the contrary, in the fair skin phototype, the acral lentiginous melanoma does not represent that big portion of melanomas presenting in fair skins. That's why detection of melanoma in darker skin is much more retarded. It's much more delayed because it's in not accessible, not visible sites, and because of the competition of the melanin, the main chromophore of the skin, with the chromophore of the skin insult that's present over there. Adding to that, the presence of the keratin as well. Okay, let's have some practice. Skin phototype 4, multiple pigmented lesions all over the body. Let's have a look. Can you witness any difference than what you see in fair skin phototypes? A bit more pigmented, maybe. Some darker homogeneous center, yes, but they're still the same. The fine reticular pattern, the homogeneous, the symmetry of the lesion, the presence of the abundant pigment network, it's all the same. Also, if we keep on searching all the lesions of the body, we'll find the same thing. So there is no big difference, but we have to appreciate the differences. Another example, a younger girl, congenital hairy melanocytic nevus, the pseudo network is preserved. Even at higher magnification, you can visualize that it is perfectly present over there. What about the palmar lesions? Here we have the lattice pattern, where we have the pigment present in the furrows, which are parallel, and we also have perpendicular lines over that, and it's perfectly benign. A halo nevus. This patient had vitiligo, and he had halo nevi, and we can appreciate the hypopigmented halo surrounding the nevus due to the invasion by the autoantibodies to decrease the melanin in this area. And we can see the regression in the pigment of the lesion, and you can see all those homogeneous clots. And this is really what I call a pain in the neck. This is a recurring nevus in a scar. Please, especially when you're dealing with darker skin phototypes, if you diagnose the nevus and you are going to take it out completely. You cannot leave remnants of melanocytes, or we'll have this picture, which we cannot confirm, which we cannot comprehend, which will leave us in doubts. So please, when dealing with a melanocytic lesion, take it out completely. Again, recurring nevus in a scar. You can appreciate the white color of the scar over there. Reads nevus, same thing. And the acral lentiginous melanoma. That's why. Detected late, we are in an advanced stage. The prognostic signs are present in the center, but the diagnostic signs are at the periphery in the form of the parallel ridge pattern. And on the left, for those who are juniors who are using dermoscopy, on the left we have the clear traditional parallel furrow pattern, which is unmistakable of the thin lines with the pigment, which is characteristic for benign lesions. And the one on the right, the parallel ridge pattern, which have the pigment thicker than the other one on the left. And it's always present at the periphery because it represents the horizontal growth of the melanoma. Okay, there have been many reviews of literature in order to gather all the information about what I'm talking about melanocytic lesions, about skin neoplasia, and it indicates the same, or it concludes the same things that I've been telling you through the previous images. The dermatofibroma, more or less, has the same appearance. The acquired nevi, except for the central hyperpigmented part, the incidence of the acral lentiginous melanoma is higher. The ethnic melanonychia is definitely higher in the nails of persons with darker skins. For the pigmented BCC, same findings. Likewise for the pigmented bowens. And the incidence of having pigmented bowens or pigmented BCC is definitely much higher for dark skin phototypes than fair skin phototypes. Also, this one was really interesting. Enzo was part of the team with Emilius and Zoe, Elizabeth, and Emmanuel about how there could be changes of skin cancer based on the skin color. So there were differences between the BCC in Hispanics, Asians, and Africans. Definitely, there are more pigmented structures, more amount of melanin laden in the islands of basaloid cells of the patients with African or dark skin. Also, if we go for the squamous cell carcinoma, because this is not a lesion that is usually pigmented, there is not much changes that can be observed, but we can see the loss of the heavy pigment network that was originally there at the site where the SCC was developed. And we've talked about the melanomas and the differences between the incidence in dark skin phototypes and fair skin phototypes, in addition to that regression can be more in melanomas in dark skinned individuals. So some cases, and I'd like you to play with me. Here you see there is this growth at the inner canthus of the right eye of this 65 years old male patient. It has been there for 2 or 3 years. It's a bit pigmented. So what do you think? Okay, let's see the dermoscopy. Was it helpful? Yes, definitely. We have this sharply marginated lesion. We have those milia-like structures that are present over there, and we have those comedo-like structure. We also have this invagination of the border, and yes, you're correct, this is a SEB-K. This is a classic dermatofibroma, as you can see, central structureless white area with the fine pigment network-like structures at the periphery. And this one is really important. It's the MF, the cutaneous T-cell lymphoma in darker skin phototypes. We know about the appearance of the MF in fair skin phototypes with some orange background, with spermatozoa-like blood vessels, with some fine scales, but in darker skin, it's totally different. This one has been reported, but I've seen it earlier than that. I've seen it like 12 years ago. It was the same. We had like this poikilodermatous appearance of the skin. Much pigment is present down there, much less appreciation of blood vessels, much less appreciation of the orange color, and there is encroaching pigment on the eccrine and the follicular openings. So this is how the how is the MF is totally different than its appearance in fair skin phototypes. Pigmented lesion, 2 years duration, right temple of a 4 phototype. Okay, great, Dr. Paula. Yes, this is a heavily pigmented BCC. I've just mentioned that there is a higher incidence of having more melanin deposited in the islands of basaloid cells in darker skin phototypes. Why it is not a melanoma? Because we have to appreciate the background. When the background is a pigment network, then it's a melanocytic lesion. But when the background, as we see over here, is basically erythematous, then this is not a melanocytic lesion. There is no pigment network, and all those are islands of basaloid cells, heavily laden with melanin, giving the appearance of maple leaf-like structures that are all fused together, in addition to the arborizing blood vessels that are more appreciated by higher magnification. 32 years old female patient suffering from this nodule of 2 years duration, heavily pigmented, but with dermoscopy, the pigment is less appreciated. And we can see that we are dealing with a case of pigmented BCC as well. We have spoke wheel-like structures. We have blue-gray ovoid nests. We have arborizing blood vessels, a little bit, but they're there. We have the ulceration, and we have yellow structureless areas as well. This was really interesting because this man had 2 adjacent BCCs. The one down there was a nodular BCC, and the one above it, which is almost triangular, was more or less a superficial BCC. And you see, you can appreciate the pigment present in both lesions. On the nose, skin phototype 5, 3 years duration, and this is a more invasive form of BCC. We have the pigment, but we have increased keratinization. This was a basisquamous BCC, a basisquamous carcinoma by histopathology. And this one, much pigment of 12 years duration. She was refusing treatment, and this was also a BCC. It started mostly as a superficial BCC, but kept on spreading, and there are all those islands of basaloid cells and structures. Patients suffering from multiple pigmented BCCs in dark skin phototypes. You can appreciate the beaded border of the lesions as well. All the structures. And this one was interesting because when I first saw the patient, my impression was that I'm dealing with a case of DLE, but actually it was not. You see, maple leaf structures, spoke wheel structures. It was a superficial BCC with all those pigmented structures over there. And this one was really interesting as well, because this 60 years old male presented with this skin lesion. And what do you think? Yes, Dr. Paula, you're correct. After seeing all those BCCs, you might get confused. Don't always think of the bad, of the ugly. This is, yes, a senile comedone, a big comedone. Yes, you're correct. Perfect. You can appreciate the homogeneous appearance and the color of the comedone itself. Sometimes you have pigmented lesions that look alike, and we care about the different behavior, not about the looks. So let's have a closer look. The one on the left is apparently a or an angiokeratoma. Yes, perfect, an angiokeratoma. It's the same thing that we see in fur skin, but here it's a bit more darker. And the one on the right actually is a very interesting presentation of dermatofibroma. It's an aneurysmal dermatofibroma or hemosidrotic dermatofibroma, which has this characteristic pattern of rainbow pattern appearance with this bluish background and the tinge of colors of yellow, orange, and red with the pigment-like structure at the periphery. And it's the same that appears in fair skin phototypes. And these triplets I really like a lot because I've presented them with FotoFinder a couple of years ago. And you see, we have a heel, and a big toe. And these are the classic suspects. Letter A is plantar wart with all those thrombosed blood vessels down there. But B and C might a bit tricky. That's why I always have my secret weapon, which is the surgical blade number 22. When we go for skin pairing, we find that lesion B is just a subcorneal hemorrhage, a talon noir. And C, unfortunately, is a nodular melanoma. And as I mentioned, in the center, there is the vertical growth part of the lesion representing its most nodular part, and it's appreciated by the blue-white structures. And at the periphery, there is the diagnostic part with the parallel ridge pattern representing the area where there is still horizontal growth rather than vertical one. In spite of having skin phototype 3, she's having a or an amelanotic melanoma of 6-month duration on the back of her right ear. She was 52 years old. And as you see over here, almost no pigment at all, but you can appreciate the appearance of irregular polymorphous blood vessels on this polypoid tumor. And this was a polypoid variant of nodular melanoma, which is really aggressive. This one was tricky for me, skin type 3 to 4. She mentioned that she's having this lesion on her right malar region of 1-year duration. She applied topical superpotent steroid. She was improved for like 6 months, and then it recurred. When I first saw that patient, that was like 12 to 13 years ago, I thought to myself, maybe it's an annular atrophic lichen or so because of this violaceous color at the periphery. But actually, pathology came back that it is a BCC. So it can happen. It doesn't mean that if the patient is having darker skin, that he necessarily shall have higher amount of pigment in his lesions. It can also be as its appearance in fair skin phototype. That one was interesting. It was a B-cell lymphoma, actually, and we know now that there is no much criteria for B-cell lymphomas, just erythematous background with serpiginous blood vessels and some irregular polymorphous ones. Sclerosiform BCC, in spite that the patient is skin phototype 3 to 4, but there is less pigment, very little pigment, just a bluish hue in the center. And we know that it is a sclerosiform from dermoscopy, no need for the pathology in this particular case, though it was confirmed by pathology, because of the appreciation of the fine, well-focused blood vessels in the center of the sclerosis, and the thicker arbrizing blood vessels at the periphery where the sclerosis is less. This case actually was a superficial BCC, clinically appreciated as an eczema, maybe some bowens, and you have to think of superficial BCC. Though it's not the usual color, the patient was in her 80s, and we could detect by dermoscopy all those fine erosions and fine telangiectasia at the periphery. And that was a clue for the diagnosis of superficial BCC. And here is Kaposi sarcoma in dark skin phototype, same rainbow pattern, but you can appreciate the darkness of the underlying skin. Cherry angioma, likewise, the same thing, same findings. And this one was really interesting because when you have a look at those, you can clearly say that they are both angiomas. But this is the clinical of a 3-year-old Nigerian girl, skin phototype 6, hemangioma. And this is the scalp of a skin phototype 4 Egyptian boy of 1 year old, who is 1 year old. And you can appreciate the difference in the color where you apply the polarized light on the left and the non-polarized light on the right. This was a squamous cell carcinoma of the heel, much keratinization and irregular polymorphous blood vessels. This boy was suffering from xeroderma pigmentosum. He has been absent for 2 years, follow-up, and he returned with 42 pigmented BCCs of the face. Back lesions, the one on the left is a classic SEPK, cerebriform appearance, and the right one is actually a tick. 4 lesions that might look similar, but dermoscopically they are different. This one was a BCC, second one is a SEPK, third one is an angiokeratoma, and fourth one is a blue nevus. Watch out. These are 2 lesions, not just one. The lower one is a SEPK, the upper one is a junctional nevus. Any thoughts? Let's apply some fluid. It's an angiokeratoma. It's in a darker skin phototype. You have to do all your tricks in order to appreciate the lecny in spite of the dark color and the hyperkeratosis of the lesion. Again, pigmented BCCs. We've seen that one. Ethnic discoloration of the nails. Whenever there is more than one nail affected, this is something that is not troublesome, usually. It's homogeneous from the proximal till the distal nail folds, same thickness, same color, no deposition of pigment in either the proximal or the distal nail folds. And this guy had a motor car accident 12 years ago. He had a skin graft. You can see it's covering almost all over his scalp. And after 12 years, he started developing these lesions. And unfortunately, he had 14 BCCs at the time of presentation in the scalp. I believe by this, I've delivered different cases that highlights the difference between fair skin and dark skin. I hope they were beneficial. And Moha and Catherine, the mic is yours at Bad Bernbach.
Dr. Sadek, thank you very much for the cases.
Lots of hearts flying up.
Guys, meanwhile, we look at the questions maybe. Enzo, there is an event in Dubai, I think next week on Dermoscopy. Can you tell us about it? What is it? What's going on in Dubai?
Yeah, we will have this event next, not next week, the following week.
Right.
And it will be me, Giovanni Pelagani, Caterina Longo, and we will discuss about, the new findings in dermoscopy in several fields. So I hope that, people from the Middle East may join us to this workshop. It will be practical. And thank you very much also for supporting us.
Enzo, tell us about this workshop. Is it the first time it's taking place in Dubai? And is it going to be annual then? Is it going to be repeated every year?
Yes, yes. The idea is to move this workshop towards the different countries of the Middle East. So for this year, we thought about Dubai, because in Dubai there are so many congresses, people are very interested. So we thought to start there, but even in other countries of the Middle East, I'm seeing that there is a lot of interest, growing interest in dermoscopy. So hopefully we will do this congress next year in another country.
Absolutely. No, I fully agree with you. The Middle East is very evolving. I mean, in terms of dermoscopy and trichoscopy at the same time, we see that. I would like we have prepared two questions for our audience. And
But maybe before we come to the questions, do you have any comments, Enzo, about the presentation from
yeah, the
Ahmed,
comments.
was
Yeah, it was
created?
great. It was great. As Ahmed showed, things may be completely different. First on clinical ground and then on dermoscopy. So we have to be very skilled about skin of color because it's different. And especially, okay, there are some countries in which colleagues are used to see dark skin patients, but there are other countries in which dark skin population is growing, especially in Europe. So we have to change. We have to learn something more compared to what we know. And also for countries in which colleagues are used to see dark skin phototypes, it's something new. So we have to discover everything together.
Mhm. No, no, absolutely true. Absolutely true. Let us maybe have we have a question in the audience. It says, how to do wet them? I suppose it means immersion, right? Dermoscopy with immersion. Is that true?
Yes. Well, if the lesion is flat, we apply a drop of alcohol, even a drop of water. It's okay. But if the lesion is nodular, we have to apply something more viscid, like a transparent ultrasound gel, in order to stay on top of the lesion, not to flow down immediately when we put it, and not wait on top of the lesion till we apply our dermoscope. So this is how we do the immersion or the wet dermoscopy.
Excellent, excellent. People, let me come to my questions. I prepared two questions for you, for the audience, and I would like to ask our two speakers to then comment it. The first question is, can you tell us if you connect your dermoscope to your phone and use it for digital dermoscopy, do you collect pictures on your phone using your mobile and connecting your derm light? It's very important for me to know because the Ahmed and Enzo, both of you, I think you agree that when it comes to the learning process, collecting images, sharing images is absolutely one of the, I would say, one of the hobbies of the dermoscopist, and more even the passionate dermoscopist. So do you guys use your cell phone, or do you use other tools for imaging?
It's very practical to use the mobile. So it's done every day by me, by my collaborators. And of course, it's important to collect images because, we don't have in many fields of the inflammoscopy, skin of color, dermoscopy, we don't know anything. So the only way to learn is by seeing images, by analyzing images. So that's very important because if we don't have images, we cannot know how the dermoscopic findings look like. So it's vital. And if we have something complex, maybe people may be discouraged to take images. But if it's simple, we have our derm light, for example, we can use our adapter and and take photos with of course our mobile. Now you are developing, I can see on your table the new device which will facilitate, of course, our job. But it's vital to take images.
Look. I mean, for those, it is interesting because close to half of our audience does not use the dermoscope with a phone. I suppose in many cases, indeed, the adapter is missing because it's not a standard, let's say, piece of the configure of every derm light. But we will definitely share information about this adapter with all of you because, as Enzo said, you can connect your derm light to your phone and take pictures. But our idea with the time was to make it faster, more ergonomic, and better calibrated. Guys, calibration plays a big role when it comes to dermoscopy, because you want to have a standardized images in size, I mean, in terms of zoom, in terms of colors. And once it is calibrated, the intelligence, like our AI, can even be more effective, helping you. I mean, we have in this device the AI for mole, for lesions, analysis of lesions for benign malignant lesions. And we are at this moment also coming up with a tool for hair. So generally, I suppose our long-term goal at FotoFinder and Downlight is to have also mobile stationary devices for digital dermoscopy. Of course, the difference between this and your Downlight connected to your phone is that with that, you could probably go faster, more ergonomic, doing a screening of the patient, okay? My second question that we will ask you is, generally, if you think a stationary intelligent mobile dermoscope could be interesting for you, if you like to have information about it, we'll definitely share it with you in the after this session. But Dr. Sadek, I think you have had this device in your hand. Do you think, especially for countries in Africa, Asia, countries that have traditionally really not had really much access to FotoFinder devices due to cost, etc. Do you think that this would be rather a solution for those countries?
Yes, I'll start by answering the first question and going through the first to this one.
Yeah.
Because if you're asking if we're going for photography with dermoscopy, yes, definitely. And what devices do we use? We use everything that we can have our hands on. But this depends on the setting for sure. So if you're in a big institute, you have a big workflow, and you can afford to have a full machine with the tower, with the full body imaging, and you add to this the support of the AI to the software, and you can utilize the video dermatoscope. This is perfect for such a setting. But if you're having a small private practice, if you have more than one practice in different places, you have to use something that is more easy to handle, but yet not compromising the capabilities of imaging and of software support and AI. And that's what is unique regarding the skin. And let me say about the MISMA as well. So we can use the photography with the MISMA, and we can use the dermoscopy with the skin. This will help a lot people who have a smaller scale, let me say, put it in these words, smaller scale practices who are seeing many patients, especially diverse patients from different backgrounds, because this is a versatile solution that does not compromise the quality, the access, and the end result.
Mm-hmm. No, very well put, Doctor. The audience just asked about magnification. Yeah, I mean, definitely one of the advantages of this device is that it provides you with standardized magnification. We start with 15, 20, and 40x. 40x is even very interesting when you do measurement of hair shaft, etc. But again, the calibration allows us to go with a standardized augmentation and magnification. I think, again, in Dubai, those of you who will be in Dubai, hopefully, because I see that we have today quite an audience from Middle East with us, go to Dubai and you can definitely have hands-on on this device and test it. IMCAS Paris, we are there. You can come to our booth and test it, because Dr. Sadek, it's a lot about ergonomy. To be honest, something that we have collected as a feedback is that the moment you need to take the time to take your Dermlight, connect it to your phone, then hold it, it maybe for 1-2 lesions, it's fine. But the moment you really want to do screening over the entire day, it becomes a little bit unprofessional, because your phone might ring all the time while you are working. So it's not working. It's not the right solution maybe for screening. But for this is one of the motivations why we designed skin, right?
Absolutely.
And
I agree.
please, yeah.
Especially about the point of calibration, because only the ones who have struggled with going for mobile phone photography with dermatoscopes can appreciate and understand well what you're saying about calibration. You can have the same lesion with totally different colors if you are not just focusing on the right point, if you're not just allowing proper light exposure, if you're not going for the right brightness. So having a device that is dependable this way will definitely solve the problem.
Absolutely. Enzo and Ahmed, I would like to tell you that we at this company um, are learning, especially your lectures of today will be also shared with our technicians, because you can imagine that something that we can take out of your presentation, and especially the contrast between fair skin and skin of color, is that also the AI needs to learn that, because the AI is at the moment very well trained on fair skin. And based on publications that we have had and also the workshops in Academy on AI, you can see that our AI works with a quite good confidence on fair skin. But the moment we move toward phototype of skin 5 and 6, it really becomes absolutely inaccurate, and it needs a different algorithm. Enzo and Ahmed, my question, what do you think, what are the top 3 cases that the AI should learn on darker type of skin in terms of the diseases that are very common?
Sorry, Mo, I didn't get it.
I would like to know what are the top 3 group of cases of diseases, skin diseases in the phototype of skin 5 and 6 that you would say the AI must be very well trained on that, because it's just very common.
Yeah, there are so many, Mo. So when it comes to inflammatory conditions, we have a lot. We have a lot. I think that the ones I showed you before are the most common: eczema, psoriasis, lichen planus, prurigo nodularis. But I think that AI may make the difference when we have very similar shades of some findings, because I think that if we develop AI in this sense, we may make some differentiation easier. Okay, so in pigmented facial dermatosis, for example, there are some subtle differences. I don't know if every of us is able to to spot these differences just by taking a look at the dermoscopic picture. Of course, if we are well trained, okay, we can spot differences. But I know, if we train the AI in this regard, I think it may be very, very helpful in facial pigmented dermatosis, especially.
No, that's very good comment. Dr. Sadek, how do you see that?
Facial diffuse erythematous lesions, facial diffuse melanosis, nevi versus melanoma.
Okay,
That's
guys.
That's the statement.
No, absolutely.
Yeah.
But I think we all agree that on the fair skin, we are very much focused on benign and malignant lesions. We have subgroups. In the darker type of skin, we would probably go with a large focus on inflammation. I agree with you, Enzo, and subgroups. But of course, our goal and objective in this company remains to save life. We will put a high priority on all types of lesions that can be deadly, okay? And we know that, thank God, in Africa and in areas where we have got a skin of color, the mortality rate due to skin cancer is much, much lower compared to fair skin. But still, it will remain our philosophy when we develop such tools to save life and maximize life quality.
And we agree also that it's very important to have regular education. So we will also push this topic in our academy at least once a year in an online academy. And there are lots of events coming up also this year, maybe some announcements. You mentioned already your course next week, Enzo, in Dubai. There's also a masterclass in Dakar. So really in the middle of it's in February, and it's the topic. This topic will be the main topic, I think.
Can you imagine the president of South African Dermatology Society? I mean, the next president is going to be the Professor Dlova, and she said she's going to dedicate quite a lot of courses for this year's. I think it's going to be in Durban, and they're going to really dedicate also more time to dermoscopy. I mean, the awareness is growing. The awareness is absolutely
growing. Yeah,
absolutely.
And some more announcement from our side. We will have the next academy in February, on the 21st of February. It's the Mold Bowl. So you can win great prizes.
Do we know already what prizes? The Dermlights, for sure?
I'm sure, yeah.
Even DR5?
This I don't know yet.
Oh.
It's a surprise, but it makes sense to participate. And we will have a live academy in London this year. It's in December only, December 6th.
End of the year.
End of the year, but it will be a full day together with Jeppy and Emilios, with a nice networking party at the end. So save the date. There's more information
Long
coming
time,
up.
Catherine.
Long
Long time. But
yeah, but first we will meet at several conferences also, maybe the AAD, IMCAS, as you mentioned, and where
visit us. Visit us. People, when it comes to questions of the audience, do we have any more questions of the audience here? Or is our audience shy today?
or tired, hungry, thirsty.
Let us see. What do we have? How about automatic image processing on mobile phone? Very often there is color and contrast manipulation. Oh yeah, true. That's exactly what Dr. Sadek was talking about, in my opinion. Again, our goal is to standardize everything as much, all the parameters that we can. That is why we designed products like Skin. But again, in this field, in my opinion, there is a lot of room for development, and we are on it. Very good. I see that questions.
Does it have polarized light, the Skin? Yes, sure.
We will share with you Skin details. I mean, definitely you will get that information, but it's a Dermoscope as you know it from FotoFinder and Dermlight with all the important parameters, everybody. You will get that information, okay? In terms of liquids for immersion, as Dr. Sadek said, for dermoscopy of flat lesions, we highly recommend water or alcohol, and nodular lesions definitely, and also for nail, we highly recommend gel because ultrasound gel is easier to deal with. That's true. That's true.
Yeah.
Absolutely, absolutely. The recording of this will be available by Monday. By Monday, you will be already having the possibility to watch the recording of this session.
And you can find all information about Skin on our website as well.
For sure, for sure. Dr. Sadek and Enzo, please share with us, the last words are yours. Please tell us how you're feeling, what's next for you.
Go, Ahmed, go.
Okay. Thank you for having me for this very beneficial gathering, and looking forward to meeting in Paris.
Looking forward to meeting. By the way, everybody, in Paris, we're going to have lectures dedicated to topics like trachoscopy, like dermoscopy, with Dr. Sadek with us. We can have soon the possibility to book and be with us live and have hands-on devices and listening to Dr. Sadek's experiences. That's definitely something we every year have at IMCAS, so you can visit us for that. Enzo.
Yeah, I would like to thank you because you're very keen to expand the knowledge on dermoscopy, and it's not so common, to find from, a company. So I have to congratulate you because you're doing a very great job. And I have to thank all these people because I saw that there were nearly 200 people connected, and this is in this time is I don't know, here it's 5 p.m. and it's Friday, so it's not so common to find all these people. This means that skin of color is a very interesting topic, and we have to go on with developing this topic. So thank you very much. And see you in Dubai for the ones are from the Middle East.
And it's because of you both
absolutely.
that people stay connected.
Absolutely. No, guys, we are FotoFinder and Dermlight have lived from your passion and commitment to dermoscopy. And this gives us actually the motivation to do this job, right?
Yeah, and we will even expand the academy to really have every month a nice topic. And it's for free. Stay connected. So we're looking forward to the next editions.
Excellent. Thank you very much to both of you for dedicating your Friday afternoon to us. Thank you a lot.
Have a good continuation of your events and lectures, and a nice weekend as well, everybody.
You too, Catherine.
Thanks a lot, everybody. Have a good time.
Greetings to the world. Bye-bye.
Bye-bye. Bye-bye.
Bye.
Bye-bye. See you soon.